welcoming. Okay, you've now got the message. It's definitely being recorded. So I'm going to start today's session, which we've called Developing Inclusion, Substance Use Related Stigma Across General Practice. I think it's going to be a really interesting session. We like at the Anti-Stigma Network to kind of take an issue, look at it from different angles, turn it upside down, shake it around a little bit and see what we can learn from each other. And I think today's session will be really insightful. I'd like to welcome our three experts who will be talking to you today. I'll do a proper introduction to them very shortly, but I'd like to introduce Joss, Byrne and Hugh, our experts, all doctors, all with really significant engagement in substance use with different insight into stigma that will be sharing with us shortly. Just before we do that, I will introduce Joss very shortly in a little bit more detail as our first speaker. However, before I do that, I'd just like to tell you about the Anti-Stigma Network very briefly. So the Anti-Stigma Network aims to improve the understanding of stigma and discrimination experienced by all people affected by drug and alcohol use. It's been created by a group of organisations with a shared mission. We aim to help coordinate and amplify the huge variety of existing anti-stigma work across the UK, maximising our shared effort to take action to end stigma. We've got a really broad membership. We welcome people from all sectors, all walks of life, with all sorts of different experience. We have a broad membership base with people from local national government, charities, treatment providers, emergency services, universities, healthcare workers, medical professionals, individuals with lived and living experience, and people who are interested, curious, people that just want to find out more. We welcome everybody. We have about 1,500 individual members. You don't have to join up or be a member to take part in our webinars. If you do sign up as a member, it's all free, and you get a monthly guide which highlights a whole range of anti-stigma practice going on across the UK and beyond. And we try and help link up members to support each other. So you don't need to join, but if you do join, it's all free. There are some benefits to doing so. We also have 26 organisational members who sign up and share the information through their staff, and we learn about what we can do at an organisation level as well as an individual level. We are non-party political. We are intersectional in our work. Lived and living experience is centred in our work. There's a place for everyone. Yeah, please do join. Last thing I will say before I introduce Joss is that we also really welcome your feedback. And so we've had some really interesting feedback from our first two sessions, which I might try and touch on at the end because I'll do another reminder. But please do let us know if you've enjoyed the session, what you've learned, what you would like to hear about in future sessions, because this is the third of a series of 3 webinars, and we are looking to plan our next series of webinars coming up, which will be coming up shortly. So without further ado, I would like to introduce Dr. Joss Bray as our first speaker. And Dr. Bray was a psychiatrist before being a GP. For 14 years and then moving entirely into substance use. We talked earlier about how some of this, Joss will correct bits of this bio, which might be not entirely accurate, but I'm hoping it's pretty good. He has extensive experience and expertise across a wide range of medical practice in substance misuse treatment, including psychiatric settings, general practice, community substance use services, residential treatment services and prison environments. He's been awarded both the Fellowship of the RCGP and Fellowship of the RC Psych in recognition of his work. He's also been involved nationally in producing NICE guidelines. He's also the founder of Competent Compassion, which is a gold standard ethos for quality of care across health services. And at the end of the session, we will hopefully have time for Joss just to direct us to any of his latest work he would like you to be aware of. But for now, if I can welcome Dr. Bray as our first speaker. Thank you.
Thank you very much, Jim. It's great to be invited to come. It sounds like a big introduction, doesn't it? I hope you find what I say useful. It's about one of my real pet subjects, and I love to share this sort of thing. So it might be not quite what you expect, but we'll get onto that. I'm going to share my screen now, and here we go. Right, so there should be a slide, reducing stigma in general practice. Have you got that one? Okay, right. I'll assume you have got it because I can't hear anybody.
All good to go.
All good to go. Excellent. Right. Okay, so this is what we're about today. I work for Way Through. I'm one of the senior clinical team. I work part-time for Way Through and also for another organisation. And I am passionate about this subject, so I hope that comes across. So what we're going to start off by looking at is, if this works. There we go. This is an interesting way of looking at the problem and the issue. And I want us to imagine, how would you want to be treated if you went to your GP surgery with a drug or alcohol problem? Just have a think about that. How would you want to be treated? You go into your GP surgery, you're pretty desperate, you want some help. Or even perhaps more poignant, if your daughter or your son had a problem and they went into the surgery, maybe you went with them or maybe when they went on their own, how would you like them to be received and treated? I think sometimes this helps us to focus on the issue at hand. It's not just about other people, it's about all of us. So here's the next scenario. You actually go in, or your daughter or son goes in, and how would you react if you were looked down on, treated dismissively, not taken seriously, not listened to, spoken to harshly, ridiculed, denied help, or banned even, or just ignored? I think we've all possibly seen examples of some of these. If it's not happened to us personally, we've seen it happening. What might you do? Well, you might protest. You might become upset and angry. You might use forceful language, or perhaps even kick off, in a polite way of putting it. And that's people who, and that's people with jobs and things that we can express ourselves. But actually, the way we're treated can really affect the way we treat others. And if we're treated badly like this, then just think about it. What would you feel? So I would say it's no surprise that sometimes people do behave like this when they're treated like that. Or maybe they just leave the service and they never come back, and they just put off getting help from a service forever, which is terribly sad. And I'm just surprised it doesn't happen more often, the way I've seen people being treated sometimes. I think people are often incredibly patient. People have problems and they keep persevering and try to get help, and they try to get appropriate treatment. So if we put it in this context, we're looking at stigma, and we're looking at how that can cause people to behave, and we want to change that because it's no help for anybody. So what can we do about it? So I think the key is to focus on a one-to-one interaction. And now for me, it's patients, other people they're called clients or service users, and the other side of the interaction is the doctor or the worker professional or receptionist. Just insert whatever you feel comfortable with. And this one-to-one interaction is what actually means something to people. What actually that's their impression of the service, maybe the first impression, and it's a lasting one. And this is so important. And obviously, the one-to-one interactions are really important as you go through the service, as people get help. So how do we facilitate that? How do we make sure that's good for people? Well, I'm saying that there needs to be a simple and effective ethos. I'll call it an ethos, for want of a better word, to guide the quality of this interaction. Because it's great to say, yes, it should all be great, but actually, what does that actually mean in practice? And it needs to be something meaningful that we can describe. It's something that's easy to understand, simple to remember. If you're anything like me, you can't remember more than 2 words in an acronym. You want something easy, simple, straightforward to implement. Brackets, doesn't cost any money, close brackets perhaps. And ideally, it should be able to be quantified, this ethos that guides these interactions. So that's quite a big call, really. And it sounds like a magic bullet, but I think we can make progress on this. And if we can get this right, and this is how we can reduce stigma and break down barriers in healthcare. So what I'm suggesting is what we need to be is both competent and compassionate towards people, which we'll just explore it a little bit. And I believe this encapsulates the most important characteristics of any interaction in healthcare. So in summary, people need to be treated with competent compassion. 2 words, very easy to understand. Okay, so I would say that one without the other, if you think about it, is at best not going to work, and at worst it's dangerous. So if someone is just very competent and has absolutely no interpersonal skills, relationship, there's no sense that they're trying to care for the person, they're just being competent, then people aren't going to engage very well with that. And if someone's just compassionate, that's great, but actually heading for disaster if there's no competence. So it's not one or the other. We can see examples in our experience of people who've been just too competent and not compassionate enough, or too compassionate and not competent. We need both of those things. We know that competence is a well-known concept. People tend to measure it in terms of qualifications and certificates and experience. Whether that is entirely sufficient, that's another matter for discussion. But competence, we always hear about, don't we, areas of competence, how to get that measured in terms of checklists and all those sort of things. Compassion is being increasingly recognised as being of vital importance in health and social care. You read a lot about compassion these days, compassionate care. And that's especially in relation to trauma and being aware of trauma in people's lives. What has happened to people? And how can we not do it again to them? How can we not traumatize people again? And therefore risk making things worse, as we said at the beginning, rather than better. So those two concepts are well known. But I'm saying if we put them together and we remember them, competent compassion is the simple and most memorable concept that encapsulates the important and essential parts of individual care. So this is what I'm proposing. And it sounds simple. You think it was sort of sensible and simple, wouldn't you, and easy to do. But I want this to become a gold standard in healthcare and maybe social care interactions and other places, because it refocuses us as service providers, if we're a service provider, on what is needed. It focuses commissioners and practitioners on what matters most to the service user, which is what we're looking at here. What matters most to that service? Interestingly, it's the interaction is the one thing that's not really measured at all by the likes of the CQC. There's no, you've got proxies of that, but nobody looks at that actual interaction in detail, because that's where it's actually happening. And for this to be a good interaction, we'd hope that that's what you and I would want for our family, or for us. When we think about it, we want people to be competent and compassionate towards us. And if that became a central marker of quality, I think this will almost certainly reduce difficult situations and unnecessary confrontations. It's something I've been trying to do, for example, in prison for the last 10 years. I have found that if you treat people with competent compassion, then the likelihood of kicking off is very, very low. And remember, I work with people, the people I work with are people who come into prison with drug and alcohol problems and all sorts of other problems. And sometimes you have to say no, but But if you treat people like this, then the vast majority of people respond to that and are grateful for any help you can give and care. If you don't treat people like this, then very quickly things can kick off, as a lot of us probably had experience of. So I would really advocate for this. I tend to try and teach all the people who come through on training or shadowing. This is a core of what we need to do. Okay, taking it a bit further, this ethos could be the core of our organisational working at all staff levels. Wow, that would be something, wouldn't it? If management staff relations were all about competent compassion, let's imagine a golden world that might happen. And between staff, between levels, I mean, that's bound to affect how service users are treated, isn't it? You know, if staff are treated well, that is much more likely to translate into service users being treated well. If staff are treated badly and it's a bad working environment, that is, I would suggest, often translated into a bad service environment. It's a parallel process. It's something that is almost unavoidable. Maybe it's too revolutionary for organisations to think about it like this. Maybe it's too hard, but we can dream, can't we? If we could instill competent compassion as the way of doing things in our services, that would be great. So have a think about that. That's a challenge I'm putting out there. If you want to have a little bit further, I mean, obviously it's just a very brief overview because we've only got a few minutes, but I've got a website that's competentcompassion.org.uk, and that's my email address there, jospray@aol.com. If you want to pilot this, if you want to discuss it further, just please get in touch. Now, I did mention that it ought to be something, that this ethos, that we can actually measure in some way. So I devised these competent compassion checkups, and there's 3 of them. So I think these would be very useful in different circumstances. And the professional has one, the patient has one, and an observer, and you can all of them can fill one of these in at once, or you can just be one person doing it. So, for example, a professional can be using it as their own sort of continuing professional development, as a way of just highlighting things they need to do. We'll come on to that very shortly. The patient, the person who's being the service user, can fill one in. I'll show you theirs in a moment. It's slightly worded, slightly different. They're designed to be things that you can do in like a minute or something like that. But actually, that can be a way of serially demonstrating progress. It can be a way of an organisation demonstrating good practice by collecting this sort of data. And as I say, part of developing your continuous professional development. So if we just look at maybe the professional one, so this is the person who help is being sought from. This is the question we can ask ourselves. Did we feel competent in addressing all the issues needed in this appointment? So did you feel you knew what you were doing? Okay, these are the important questions. Did you understand the relevant issues? Were you able to make an informed and reasonable action plan? And you can circle that, and you can list areas which you like to feel more competent in. It's not like an exam. It's not like a condemnatory thing. It's something to help you develop more. And then, how compassionate did you think you were? Did you demonstrate you cared about the service user? How did you do that? Did you try and understand the issues from their point of view? Did you try your best to help them? Okay. And if you didn't feel any of those things or some of those things, why? I mean, was it that the previous patient was very annoying? Was it this one's annoying? Was it you were late or angry or hungry, or tired? Just to be aware of these things is so helpful. And I know it sounds obvious, but actually sometimes we just need to stop and think, how am I doing? What am I doing? Okay, and that's going to help our patients and ourselves as well. There's one from Observer, which we won't go through that one, but there's the service user checkup. So this is what the person could fill in afterwards to give you some feedback. So how competent do you think the professional was in addressing all of the important issues in the appointment? So do you think that they seemed to know what they were doing? That's important, isn't it? Do you think they knew enough about the issues discussed to be able to help you effectively? And you can score that, and then you can then put in what areas you feel that they could improve in, and that's fine. And how compassionate do you think the professional was towards you in this appointment? So did you feel that they cared about you? Did they try and understand your important issues and try their best to help? So that's not just about a doctor or whatever. That can be a receptionist. Did they actually notice you? Did they actually listen to you? Did they try their best to help you? And again, there are areas that we can look at for improvement. This is all great feedback, which we could use as services and individuals to demonstrate that we are trying to tackle this stigma issue, which the bottom line is how you treat people. How do you treat somebody one to one? And I believe if we treat someone with this competent compassion, we can get it in our heads. This is how we're going to do it. We won't be perfect, but at least we've got something to aim for. And then somehow, and then think about it on a personal and corporate level. I think we could go a long way towards tackling this issue, and I think people have a much better experience of services. And I think we, if we're service provider, I think we'll have a much more fulfilled working life as well, because we'll be able to improve and we'll demonstrate that, and we'll be more helpful to people coming to seek help from us. So that's the main thing. That's very quickly, that's it in a nutshell. Don't forget to go to the website. Don't forget to get in touch with me if we want to explore it further. It would be great if we could sort of roll this out. It doesn't cost any money, right? It's not about that. It's just about an ethos and about a way of improving things for people. Okay, that's it. Thank you.
That's great. Thanks, Joss. So yeah, just to summarise, so people can get in touch with you via Competent Compassion website. Fantastic to hear it doesn't cost any money, so that's always a barrier for some people. But I really like the simplicity. I really like the focus of it. I think we can sometimes overcomplicate what should be human, positive interactions, and I think I really like that concept of just like make it really simple. Let's think about competence, think about compassion, and I think the measurement process is really good. I was going to ask you, I think you've already touched on it really, that what stops competent compassion, but I think you've talked about perhaps time pressures, perhaps people feeling that maybe they do lack a bit of competence, and that means they don't come across as compassionate, and that these two things work together. So I think you've already touched on a couple of those points really, and probably answered the question. But really brilliant. Thanks, Joss. Love the simplicity of it. I'm now going to hand over to Dr. Hard. And sorry, Dr. Byrne, let me do a quick introduction for you before I hand over. So you are a GP who's worked with people who use drugs for 20 years, focusing on complex presentations, both in forensic settings and with people experiencing homelessness. So if I've got this wrong, do let me know, but I understand that you left clinical practice 2 years ago after being the victim of workplace violence, which resulted in PTSD. I hope you don't mind me talking about that. I think you're going to talk about it more within your presentation. And you're talking about both your experience and perspective in the hope that it will build trust and understanding and lead to a more compassionate, there's that word again, and psychologically informed environment for everybody. And if I can hand over to you now, thank you for joining us today. Really interesting to hear what you've got to say.
Okay, thanks. Hopefully everyone can hear me. So hello, everybody. It's weird not being able to see anybody. Yeah, thanks for having me. And I'm, full disclosure, I am mega nervous because I usually give talks about abstract academic things where it's very not about me. And this is very much about me. And I thought long and hard before I decided that I would accept this. And actually, when I was asked and I told the panel what I intended to talk about, I thought they would tell me, no, that's not welcome. So it's actually really good that I'm going to be able to share some of my experience. And really, this is about perspective. And I was jotting down some notes before I get started around this. I don't know if any of you have seen the movie Inside Out. We all show up with whatever's going on the outside, and most of us got a whole committee, going on inside, all these different things that have gone on for us in the past, that are going on in the moment. And if we can maybe pull the hood up on that, what tends to happen is we have miscommunication because we don't understand what's going on the inside for other people. And then we get angry with them. There's a blame culture. Well, it must be you. You're not being compassionate enough. Must be you. You're being too angry, whatever. People feel shamed when you pull them out and you identify that they've done something wrong. They become defensive. They get resistant. It just gets worse. And I think that it's a two-way street. The way we are treated affects the way we treat others. Absolutely, 100%. And I'm here to share. I'm no expert in communication, but I seem to have become, by accident, a bit of an expert in miscommunication. I'm going to share my missteps with you. I'm going to share how that disintegrated to the point where I walked away. And I do feel really sad about that, actually, when I reflect on it. So let's get going. This is what I've pulled together. I got this off the dictionary. What is stigma? And I've got this: a strong lack of respect for a person or group of people, or a bad opinion about them because something that they've done that society does not approve of. So it isn't a reaction. I'm not stigmatized. I'm not being stigmatized towards someone if I'm having a reaction to how they've treated me or how I've experienced them. It's something that I've concocted in my head rather than something that is based in a shared reality. And again, how does that appear perhaps to the patient? We've heard that echoed by previous speaker. Negative interactions, a feeling of being judged, of being disapproved of, a perception of someone being indifferent, cold, detachment, a sense that one's being blamed in some way for one's condition, a sense of shame. And just this is full disclosure. So after I left, I actually had quite a rare medical condition, and I ended up having complex neurosurgery. So I've had a fair bit of being the patient as well in the last few years. And I do understand that now from a patient's perspective, that, if you feel that you're being dismissed or not heard, or your amygdala fires, your hackles go up straight away because you feel under threat. And very quickly that relationship can break down. So yeah, my story, and I don't think my story is that unique to people that end up working in substance misuse. In my experience, most people are there for a reason. The trauma doesn't just sit on one side of the table. I've got my own trauma history. I have some lived experience. I came to work in addiction services as a person way back 20 years ago in a 12-step recovery program myself. I, like many doctors, have got perfectionist traits. I like to do things right. I think I came, therefore, into this field as idealistic. I was probably very optimistic, very, very dedicated. And I brought to it, back in the late 90s, an approach of sort of an understanding of addiction that was a biopsychosocial model, that it was an illness with genetic predisposition, environmental factors, and elements of habituation. No stigma there, no judgment. I myself would identify as someone who struggled with addiction, and I would own all of those parts of my story. Not good, not bad, just the way that, I interacted with the world around me. One of the things that I sort of experienced, just to unpick a little bit, is this term stigma by association. Addiction services are Cinderella services. They were marginalised. They were siloed off to third sectors, relentlessly recommissioned, 3 to 5 year cycles. Budgets get cut. Organisations come in and run for profit on increasingly tight margins. They promise the world to the commissioners, and they can't possibly deliver. So it all gets very toxic. I've worked in premises that were literally unfit for habitation, where we had, broken toilets, the lights went off, the internet didn't work, the chairs flopped down to the floor when you were trying to sit on them. It was a very difficult place to work, and over time that just drains your enthusiasm and energy. We felt cut off often from the NHS systems, you know, that you don't have an NHS email, so someone will send something to you, you can't get the results. It's hostile and it's challenging and it's difficult as an environment. I mean, you know, literally, to quote, I was with a consultant colleague who was a gastroenterologist, so very much embedded within, you know, respectable physical healthcare within the NHS. And he asked me how I got appraised as someone who worked in third sector in substance misuse. And then he very jokingly dismissed the notion that I would need to be appraised to work, as he put it, with pond life. And that was totally acceptable chit chat within a secondary care service. And yes, it's not just, obviously, it's horribly stigmatized language, but it's stigmatizing me, the healthcare professional, as well. We're all being stigmatized by the environment that we work in, and it grinds you down after a while. We had political policy changes. So substance misuse is one of these areas where, more than many other things, you don't get the government changing its mind on what should be done with hip replacements or other areas of care, but they have a say in it. You know, it's very political. So we had the harm reduction in the noughties. You know, we had the let's get methadone out, being service, let's get it out and let's get people on it, which was great. Then we had this kind of, oh, you're parking people on methadone, you bad doctors, what have you done, all over the front pages of the press. You have to deliver recovery. So we had to deliver a recovery agenda, you know, without the staff to train to do it, without the setting being appropriate, completely unrealistic often. And now the winds blow back and we're in another direction. And it's hard to be at the front line of that. You know, all along I've argued that we need a blend of all these extreme pendulum swings. We need to be able to deliver evidence-based, competent, patient-centered care to the patients that we're seeing, rather than just pick up the latest party line and try and get our heads around it, because that's what that's what we've promised the commissioners that we'll do. So we're going to look like we're doing it, even if we can't. Increased societal challenges. So with all these challenges that have happened over the last 10 years with this zealous recovery phase, it was timed almost perfect timing, perfect storm, with this kind of austerity, the cuts in public services. So there was a group of more marginalized, more struggling people, and then there was a substance misuse service that was making unrealistic demands on them, and there was a lot of fracture of relationships, deeply fractured relationships, deep, you know, mistrust. It can't just be papered over with a change of policy that comes out overnight like that. And with that whole scenario came patients with more severe mental health problems, increased homelessness, increased desperation, and as a result, perhaps, or related, increased violence within the workplace. So definitely between 2017 and 2022, where I worked in South Wales, it went to something that I had not experienced. You know, it was always a little bit edgy, and yes, people would perhaps not communicate in the same way as they would in sort of mainstream services, but I liked it, and it was all right. You could de-escalate people, you had fundamentally trusting relationships with them. But with what happened in the last 15 years, that trust was eroded. You know, it's very, very difficult to maintain trust when you're telling someone, we are now delivering a 24-week program and you are coming off your script by this day. And there's nothing I can do about that, because that's what my service is signed up to deliver with the commissioners, because that's what this government got in votes on. So that went on for 5 years, and that you, in order to be the person that has to tell the desperate person on the other side of the counter, yes, that does mean I'm removing your treatment, I'm the one that takes the bullet, as it were, for the team. And that over the course of 6 years, you've got to deal with that. You've got to deal with that letting people down. You find a resilience, you find a way to cope, and it doesn't, I wouldn't call it compassion. It's very difficult to maintain. So what does that look like in terms of the interface? Yeah, they were getting angrier. My resources were getting thinner. My autonomy as a clinician was being undermined, and it was never great in these services. So the idea that I was coming in as a competent expert, but then I was just being dictated to because government policy says we're doing 24 weeks. It doesn't matter what all the research shows. It doesn't matter how you've assessed your patient. That's irrelevant. You're doing this. It's very, very uncomfortable. So by then I was experiencing violence on a weekly basis, chairs throwing around, people crashing through the doors, people threatening to slit my throat, my car being vandalized, because naturally they're angry and I'm the face of it. So I'm going to be the one that gets it. So I kind of carried on. I worked through COVID without a single break. And yeah, I look back 2.5 years after it broke me, and it did break me. And what was the last straw for me? So the reality of this, the last straw for me was literally having someone, they'd kicked through my door because the security lock had not been put back properly. And he stood over my face. He was 6'2" or 6'3", and he had 168 convictions at that point, red flagged as a danger, very, very angry, very, very dangerous potentially. He stood over me and he yelled, "I'm not doing any fucking test. You write my detox now, you cunt." That was it. I didn't leave that day, but I left within a few weeks. That was it. The impact it had on me totally stunned me, to be honest. It was what stunned me more was that it was observed by multiple members of staff who did nothing apart from, once he'd left, smashing the plasterboard off the wall next to my head. They clearly recognised that there was an immediate threat to life, and they put a barricade with a chair across the door in case he came back in. What happened next, in a way, for the services, the managers, the commissioners, they didn't like this whole thing and how it had kicked off and how I'd responded to it. And so their way to kind of wrap it up was to suggest that my approach caused it, which I think is gaslighting. But anyway, that I then received a many-page report written by a very senior member of one of those sub-organisations that we were working with, accusing me of being a safeguarding risk to vulnerable adults and suggesting that it was my approach that was a catalyst for the abuse. Okay. So, and that, my view at that point was that there was violence in the workplace which had been normalised, which I can accept. And then I was now being gaslit, being told that I was causing it. And I was being told that by the organisations that I believe essentially cooked up the perfect storm. So what did this approach look like? Even, let's take it back. Yes, cold. Yes, detached. Yes, numb. Yes, frozen. Yes, scared. I now reflect that actually, having spent 7 years going in thinking, who's going to throw a chair at me? Is it going to hit me? Am I going to have a fractured skull when I get to my car? Is it going to be scratched? I now know that it is not normal to carry a coffee cup into work with you. And when you're walking back to your car where you've hidden it in a multi-story, you think about how you would smash it on a wall and stab it into someone's throat if they attacked you. I now know that's not a normal way to live, but I lived like that for 7 years. And I thought I was showing up, right? I thought I was showing up for people where other people didn't show up for them. And that's why I did it for so long. So maybe that did look like a lack of compassion. I looked at violence in the workplace. The definition in terms of the Health and Safety Act is any incident in which a person is abused, threatened, or, I've just got to move this screen, assaulted in circumstances related to that work. Healthcare professionals are at increased risk. An NHS survey, 14% of NHS staff and 28% of ambulance staff had experienced physical violence from a member of the public in the preceding 12 months, with 25% experiencing harassment or bullying. 58% of these cases occurred in mental health settings, and frontline staff are at highest risks. And I would suggest that our services literally combine this to the point where it's, over 90%. You'd be pushed to find someone that hasn't been exposed. And what are the failings that were identified by the NHS resolutions? Insufficient risk assessments, lack of suitably trained staff, inadequate policies and procedures that often were in place but not being followed, inadequate protective equipment such as panic alarms, delay in colleague response, or also people knowing what to do in response to an incident, and also a lack of support from employers for the victims, and also a wider team, the wider team following the incident. So just to crystallize that, I mean, I once had a patient say that if they were again, it was about the safety of their medication. I was told very clearly, if I see you when you leave here, I will smash your skull in. I was worried about walking from the clinic to my car, and the senior manager said that I needed to pull myself together because our clients blow hot air, right? So yeah, I consider that to be a lack of support from the managers. What did the NHS team recommend? The recommendation was when staff experience workplace violence, a suitable package of support should be available and should include immediate and long-term physical, emotional and financial support, details of which should be held by local violence prevention and reduction policies. Managers should receive relevant training to ensure that such packages of support are delivered effectively. So burnout, a little bit on burnout, just to segue into that really. So what does burnout, this is the World Health Organization, exhaustion, mental distance from your job, a feeling of cynicism, a detachment, a depletion, which results in reduced efficacy, more common in patient-facing roles and in those that were most idealistic, most enthusiastic and most engaged to start with. The GMC reports in 2023, about 40% of doctors are at risk of burnout, and burnout arises in poorly managed workplace conditions. So, moral injury, it defines as resulting from sustained distress due to institutional or resource constraints, creating a sense of unease among doctors from being conflicted about the quality of care they can give. It leads to long-term psychological harm with a variety of negative emotions from guilt, shame to anger, and then ultimately moral disorientation. So is it stigma? Stigma is at the heart of this for sure, but my suggestion is that it does not sit with those at the front line. These people are mostly here because they care, and maybe we care too much, and often we're broken. The stigma that is driving this is institutional. It is at a government and regional level where the services providing for those who use the drugs are not given parity of esteem. And now those very institutions are scapegoating the burnt out frontline staff for not being compassionate enough. So that's kind of what I wanted to say. I'm really looking forward to the discussion at the end of this, and I hope that I haven't overshared, but open, all ears now.
Thanks, Bern. Fantastic. I think you've really given us an insight into what stigma by association and what some of the politics and the policy and the structural stigma can feel like in real life. And that's really important to hear. And thank you for sharing your experiences. And I appreciate that it's not easy. And but I think we are enlightened by your experience. And this is what societal structural stigma can feel like in real life, and I think that's really important for us to hear from you. So thank you for your time. I'm going to pass over to Hugh, and I'll do a very brief introduction for you, Hugh. But Dr. Hugh Gallagher, trained as a GP, has worked exclusively in addiction for over 28 years. He's worked in community and residential settings within public, charitable and private sectors. Now working within an alcohol-specific programme in Ireland. He still works ad hoc at Smarmore Castle Treatment Centre, where he resides as the medical director. He's been involved in writing guidelines for the Irish College of General Practitioners in the management of alcohol use disorder, and is involved in teaching doctors, where he stresses application of basic principles of humanity when supporting people affected by alcohol and other substance use. So if I can hand over to you, Hugh, thank you for joining us.
Thanks, Jim, and thanks very much. I'm a bit nervous too, but it's actually really nice to be here and to join you all. I'm going to touch on several topics that I believe are important for health professionals. So they're training, case management, and choice of treatment. So as per the introduction, I've worked for about 28 years across various different practices within addiction, having worked previously as a GP and worked for a period of time in palliative care. Now, our service was very much in its infancy when I started, and looking back, there were certain practices and policies that were, that were stigmatizing and we changed significantly over time. We were and still remain a Cinderella service, but what was good at the time was we had lots of money in Ireland at the time, or at least we thought we did. And there was lots of money put into training. And I availed of whatever I could, certainly. So I did lots of different types of training and different models of treatment and so on and so forth. Like, I did MI and CBT and CRA and resonance factor and trauma informed care and so on and so forth, and a whole variety of other things. And within that training, I suppose I certainly got a degree of knowledge. I developed some skill. A lot of the training, thankfully, was in an interagency and interdisciplinary manner. So working with people, or training rather, with people from different agencies and different disciplines, I found to be invaluable. I suppose from the perspective of simply of learning who they were, which was very valuable later on in terms of networking, knowing what they did, and I suppose hopefully they getting a sense of me and what I did as well. But perhaps the most important thing I felt I learned from the training, I wasn't going to be, I might have been doing training that was more relevant for counselors, perhaps, and people working in other disciplines. But in doing that training, what I felt I got as much or more than anything, apart from the understanding of what the models were, was it influenced my attitude. It influenced my attitude towards my patients. It hopefully provided for the compassion, the empathy that was discussed earlier, getting a sense of where my patients came from, what were the contributing factors to where they were, and as they sat in front of me, and so hopefully provided for an ability to better communicate with them. Secondly, I just wish to talk about case management. Now, in our service, first of all, I worked in opiate addiction treatment, and there was a certain hierarchy, I guess, within the service, and doctors tended to be at the top, and I suppose maybe for some time I felt I was the most important person as well. Some of that, unfortunately, because quite often I was perhaps maybe the person who certainly communicated with the patients most often. But I increasingly got more, I suppose, uncomfortable with that. And I was on a committee for far too long. It ran for quite a few years, developing a national rehabilitation framework. Now, that was obviously, a lot of it was in looking at how we develop, train, and implement care planning and case management. And so there was a very nice publication put together, and in theory, all that was being implemented. But in the 27 or 8 years that I've been in services, it's really only been in the last couple of years when I moved to work in a different service that I actually really see care planning and case management being applied. People who understood, were properly trained, did these things in a structured manner, and it was enlightening and extremely fulfilling and rewarding, because it made it easier for me and it rewarding from the perspective that you simply just got better outcomes. And so I suppose what I'm talking about there is, like, whereas I have certain roles in terms of what I do, but it's quite limited and it's quite limited in the lives of a lot of the people that I see. The holistic approach is obviously, you know, what case management is involved in, and for many people, they're not going to be able to do much with me. I'm not going to be able to do much for them if their priority is childcare, accommodation, financial, legal, criminal issues, and so on and so forth. But where you had a case manager who dealt with those things, and I could be involved as and when and if appropriate, then and very often I didn't in the setting that I'm currently in, very often I don't need to be involved at all. But I suppose I'm just saying that for people working in services, for commissioners of services, that training, implementation, monitoring that case care planning and case management is being done, updating skills in terms of training in general and case management in particular, that happens as well. I just feel you'll get a more efficient and by far more effective and a more compassionate and treatment service. The third topic I wish to just discuss is choice. So where I worked in a community setting and initially in opiate agonist therapy, again, in the early days, methadone was the only treatment option available to us. And methadone worked wonders for many people. It saved lives, it reduced criminality, it stabilized generally people in their terms of their health, relationships, so on and so forth. But when buprenorphine became available, it really benefited some people much more. Some people were much more suited to it. It offered an alternative. It didn't suit everybody, and methadone still has a very important place and presumably always will. But it was very much better for all of us, staff and patients, that there was that option available. Then when long-acting injectable buprenorphine became available, that was, to my mind, totally transformative. It allowed people to be freed from clinics, pharmacies. It vastly reduced stigma for an awful lot of people. It worked well for people who were very stable generally. But what was particularly great to see was that it worked really well also often for people who were chaotic polysubstance users, where they had a recovery mindset. And I think that was important as well. And where they engaged in case management, in effective rehabilitation. The current work that I do is in alcohol treatment, community alcohol treatment. I was involved in developing guidelines for general practice and put together guidelines from various parts of the world: UK, NICE, Australia, US, Canada. And I always say that the actual treatment that I give is fairly simple and straightforward if you follow the guidelines. But sadly, I still find that GPs either don't seem to read the guidelines, or certainly very often don't apply the guidelines. So I suppose, and a recent article in a very, very reputable medical journal stated that only 10% of people with alcohol use disorder are treated. So, and that's a pitiful statistic, really. The other treatment. So where I treat people, mostly it's detox. And again, as I say, there's simple guidelines that people can follow that are there available to all. It requires they obviously first need to ask the question, they screen, they do questionnaires, audit questionnaire, perhaps an SADQ questionnaire to see if detox is required. But should a detox be required, there are very simple guidelines in terms of the detox regime that a person will respond to and will work for an individual. The other treatment that I'm very involved with is medications for alcohol use disorder. Now, these are medications that would be given to people perhaps subsequent to a detox, or if they don't require a detox, medications that would be prescribed to help them to either stay sober or to control their drinking, minimize their drinking to an acceptable level. There are 4 different drugs that I commonly prescribe. Probably in order of preference, it would be naltrexone, disulfiram, acamprosate, and baclofen, and I use different ones depending on the individual that's in front of me, and sometimes combine those drugs. But there is very strong, long-standing evidence for the effectiveness of these. But again, in that same medical journal, in that article, it would have stated that probably only about less than 2% of people are treated with these drugs. Now, I just checked my own stats today from the clinic that I work in, and I've got about 80 patients on one or other of those drugs. It allows, if it reduces cravings or it helps people to stay sober or to reduce their drinking, it allows them to better engage with other services and support workers. It allows those services to better engage with them as well. So I would like, again, to make a plea to service providers out there, be aware and please do use these drugs, because they can have a very, very, very significant impact on the recovery potential for your patients. I think that's all I need to say. Thank you.
Perfect, thanks, Hugh. Another really interesting perspective, particularly around choice and awareness of service providers of different options and making those options available to people. All about giving people a better standard of support, improving that interaction that we talked about as being so absolutely crucial, breaking down stigma, providing choice. So we've got not much time left again, because my timekeeping is not very good, but also I think it's really important that we hear from our experts, and we've heard some 3 different angles and approaches in relation to stigma, which has been really interesting. What I'll try and do is maybe pick out one question that we can try and put to the panel, and then we will follow up afterwards and see if we can answer some more of the questions. But let me just have a look through and see what we can find. I mean, we've got a question here from Andrew about why are drug and alcohol services so professionally stigmatized, and I think that's in relation to the point that Bern was talking about in relation to Cinderella services, I think, and in relation to stigma by association. Maybe that's one we could pick up. I mean, is that a universal experience, Josh, you and Bern, across that we feel that sometimes GPs specialising in substance use or addiction treatment services tend to be viewed as lesser than in some way? Do you feel that with other healthcare, your interactions with other healthcare professionals? Is that universal, or is that something that happens? But what are your views in relation to that?
I mean,
I suppose I'm asking anybody that would like to chip in, really. Josh, you look like you might be about to speak, so I'm going to grab your motivation and see if you'll.
Yeah, I mean, I don't care. I don't care what other health professionals.
Good, that's good. I like that.
We're in this, aren't we? Because we know we can help people and we can make a big difference even in a short period of time, and that's why I left general practice to do it, because these are people who often nobody had helped them or taken them seriously before, and you can actually give them hope and a future, you know. And I know it sounds a bit idealistic, but it's actually true. So I don't care what other people think. I mean, I suspect they think, oh, well, they're doing that work over there, that's nothing to do with us, or, you know, whatever. And I do think there's stigma, you know. Some people obviously say, why bother, you know, and I say to them, well, you know, even if you don't care about the people, you save between £3 and £9 for every pound you spend treating people. So what, you know, even financially, you should bother about it, you know, even if the compassion area doesn't get back through to them. Anyway, that's my quick answer.
Yeah, I think and it's something we talk about a little bit, really. If we can't generate empathy and compassion, then there is a solid, rational, economic argument. If we have to fall to an economic argument, if that's what we need to get to, then there are many reasons to support people, moral, spiritual, human rights based, economic, whatever. Really, we will care, because we need to in all of those aspects. Can I go to you, Hugh?
Yeah, I was very disappointed at a recent meeting I had with representatives of our College of General Practitioners, when we were trying to, you know, promote cooperation, collaboration, training, and so on and so forth, when they said that they had passed a motion at their last AGM to the effect that they would not engage with unresourced activities. I think it was something like that. And it being effectively stated that we ain't going to get involved with alcohol, which, and my retort would be, well, look, you know, you've got to, I think in the stats in our here would suggest that every GP probably has 60 patients with alcohol dependence. So, and and so many more with various harmful and hazardous drinking problems and all that ensues. And if you're not going to be, you know, if you're not asking the question, if you're not dealing with it, well, you know, you're maybe treating and prescribing for lots of conditions which, you know, are secondary to the alcohol, or certainly your treatment isn't going to be as effective or effective at all. But what I suppose I did do, and in the most recent job that I took on, I made a point of going out there. They had established a very good relationship with a lot of GPs in the part of Dublin where I work. And so it was quite easy to get out to go to meetings. And so I made a special effort. I went to the practices. I went to CPD meetings and the likes that they organized. So it was about, to be honest, it was just about selling. I was a salesman. And sometimes you got to do that. And you got to prove your worth as well. But you got to be available, and you've got to be affable.
And yeah, Bern, any further insights that you could? I mean, you've already talked in detail about stigma by association. Anything that you reflect on from today?
Yeah, I mean, I think in answer to that question of why does this happen? There's a kind of hierarchy that we place around our free will and our choices and the consequences of those choices. And I think that society as a whole, we find it much more easy to feel compassion, and also to feel that there is a deservingness about treatment. Say, if you have an illness, like say a child has leukemia, that's to take the extreme version, versus someone who has chosen this lifestyle thing of going out and smoking crack or injecting into their groin or whatever they're doing. And so by filtering down the ones where there is an element of a perceived free will, choice, therefore blame, naturally lends itself to being, well, they don't deserve it. You know, there's a hierarchy of deserving in healthcare for sure, and I think that's the way in which we view our human condition. And how you get around that often, if you break that down, and you know, if you sort of unravel a person's life, then that some of that blame and some of that judgment literally does peel away, because you can then see them as a victim of their circumstances, really in no different a way to the person who's woken up one day and realized that their child has a a brain hemorrhage, a tumor or something, that either of those things have evolved because of genetic factors, environmental and habituation conditions in the environment. So that would be my take on it. It's a very, very difficult message to get out there, and it's on every level. It's ingrained and baked into the services that we work in.
Yeah, thanks, Bern. And could I bring Jot in on that point as well?
Yeah, Bern, I just absolutely about the hierarchy. Isn't it true though, in our services, when I meet people, there's a hierarchy of people in the services. They look down on each other, don't they? So the alcohol people look down on the people who use benzos, look down on the people who, crack, who look down on the heroin. At least I'm not a smackhead, and
Yes.
the sort of thing. I mean, that whole stigmatizing sort of hierarchy is just all the way through the service, isn't it?
Yeah. Yeah.
Okay, I've just been told we've got a little bit more time than I thought, so I'm going to see if I can find another question actually for us to focus on, and lots of people thanking everybody for sharing their views. What I might do actually is just pick out something from the back of my mind, really. But so I feel like saying, right, what do we do then? But I think you've already started to answer those. We talked about competent compassion. We talked about, from your point of view, Hugh, in terms of ensuring there's, I think, a kind of a rigor and effectiveness around case management as choice. And Bern, I'll probably come back to you really about what would good support look like for GPs and for our doctors working in different settings in relation to substance use. There's a sense of us, I think, needing to value our doctors and make sure that we appreciate their own personal journeys. But what do you think that would kind of look like or feel like? What should we be doing if we could wave a magic wand and make change happen right now? What would it kind of look like, do you think?
Oh gosh, you put me right on the spot. I mean, I think that ultimately it's about reinvesting in this as a legitimate medical specialty once again. So often I've been involved in working with colleagues from abroad, and I feel that perhaps for different reasons, I've had colleagues in France and Spain and Germany, and for the way in which those services have been delivered and commissioned, they don't question their value, they don't question their place. They are professionals in a sort of appropriate environment, an academic environment, a hospital environment. They're embedded into a medical service, and the system seems to work in a way that is unrecognizable to me in the UK in what's happened in the last 20 to 30 years. I think that there's reasons why that happened. It used to be a secondary care subset of psychiatry that was embedded within community drug and alcohol teams, were seen as a branch of psychiatry, and then for very good reasons it expanded out because we needed to massively increase the availability of these services. But then it's become really so is it, the way that it's funded, for example, are we treating health problems or are we reducing crime? And who's leading on that? Is the leading thinking being we are treating an illness using all of that ethical and evidence-based experience that we have in treating illness? Or actually is this money coming from justice, and actually the taxpayer wants bang for their buck because they want people not to rob, and actually where that money is coming from drives the ethos of the service. And then we as the doctors become almost just like a secondary irritation, someone that needs to sign that piece of paper before it goes out. We're just an annoyance. And I think that it needs a complete rethink, essentially, in terms of how it would work better for me anyway. But I think that there needs to be, I also think that if we look at how a trauma-informed service should be delivered, if we start from there, it might be really helpful. And actually, I researched this having been accused of being the opposite of trauma-informed, of being a traumatizer, which I know is now it was just nonsense. But I at the time was horrified and did a fair bit of research into what a trauma-informed service should look like. And actually it is safety. It is a safe service for everybody. And so you cannot deliver trauma-informed care if you do not feel safe yourself. So the hardware of these services needs investment in, and that's about money, that's about boots on the ground, that's about maintaining the building space, the facility, having a, respectful parking space, that people have offices where the lights go on when you come in, where it doesn't smell bad, where there's enough toilets for everybody to use, where also you are physically safe, and managing boundaries is really important when you've got people who are dysregulated and they can't contain themselves. They rely very heavily on that containment being in place. And it is difficult, but I think it's going to take a huge amount of investment to do that and to have it working differently. I'd be grateful if other people had any views on that.
Yeah, Joss, can I bring you in on that one?
Yeah, I mean, I just want to plug shared care really in general practice. I mean, I always felt that, I mean, obviously some place has none and some place has a lot, but I always felt that if you could normalize, if you like, treatment into normal general practice, you have people coming and going just as in normal appointments and things like that. I think that's a huge thing for anti-stigma, because they're just part of it. A huge thing is training receptionists in the competent compassion thing and all the rest of it, because and because we know what can happen and can go wrong. But if we can sort of somehow normalize it as treatment and not people people in silos and ghettos to go and get their treatment, I think obviously sometimes there needs to be more control thing, but I think I would try and plug shared care more, I think.
And another question from me, I guess, as we sort of get towards the last sort of 10 minutes, we've got some fantastic expertise here on the webinar today. What would you do to advise somebody starting out in their career? You experienced a huge amount each, personally, in terms of professional development, in terms of engaging in lots of different sectors and lots of different people. What would you say to somebody starting out, thinking about getting into the medical practice in relation to substance use? What's your advice? Hugh, can I take you first?
Yeah, I attended a Wonka conference. It was held in Dublin there last year. That's a gathering of GPs from all over the world, literally all 5 continents. I went to a workshop. Now I only didn't catch it all, but it was being summarized as and based on research as to, I suppose, what is the essence of general practice, or what's really important. Now this wasn't substance use or addiction related at all, but apparently the research suggests it's humanity is where it's at. It's the application of humanity, and I suppose in terms of the satisfaction that you get from the job, the satisfaction your patients get, and the outcomes that you achieve as well. Now, what makes for the application of humanity is a lot of things, perhaps, but I suppose just having, and it's like Joss mentioned the compassion and empathy, obviously, but it's just to keep that as an overarching philosophy, I suppose, that you will get more satisfaction, you will get more reward, you will get better outcomes if you have that approach.
Yeah, thanks, Hugh. And I guess the point that everyone's made really is that needs to be applied kind of throughout the system, so that the managers managing the other managers, and Josh, you talked about competent compassion as needing to be backed up through the, might call it, the back office, so that the front line interaction can have competent compassion. And Bernie talked about trauma-informed system theory, but we're kind of talking about systems that enable the application of humanity, aren't we?
I think if I was to suggest one thing, I would suggest that, you know, it's that thing in the airport, is in the aeroplane, you know, you put on your own oxygen mask and life jacket before you help other people. And if I could go back and do something differently, one thing, I would introduce quality supervision. You know, I do not underestimate the toll this is going to take on you. And actually, you are going to need, well, we used to have that, you know, mental health professionals retired at 55. And I used to think, oh, how are they so lazy? Why are they going earlier than everybody else, you know? And then 20 years later, and it's not just me, I have so many colleagues that are just broken. You know, healthcare is really, really tough mentally. And actually, we should get a lot more in terms of supervision, in terms of, you know, offloading all that stuff rather than just shoving it down and then using these really toxic coping strategies to keep going. So that, you know, that blunting, that gallows humor, we all do these things to survive. And actually unpicking that, psychologists have it right, don't they? All have supervision. So, you know, I think that would be one thing I would do, a reflective space.
Yeah, thanks, Bern. I think it's a really important point. Who cares for the carers, really, what we're saying, isn't it? And what can we do in terms of structured self-care and support for our professionals, in this case our GPs. But I think that's got to be part of how we address long-term healthy interactions and relationships between people seeking support, people providing support, and making sure that that's got a structure behind it, but it's got some longevity to it as well. And we talked about the importance of people being able to have positive, compassionate, humanistic interactions in settings that work for them. That's got to come with support for the people providing that care. Well, I'm going to do a final check of any questions and answers. We will any we haven't answered today. We will try and respond to after the session. So we've got some people talking about different interventions that need to be made available, and I think what we'll do is probably pick up. Yeah, I mean, there's a point actually about language. Have I got a minute? Maybe can I just touch on use of language? There's a lot of as a layperson, I'd say there's a lot of medical language which increasingly is being seen as perhaps quite clinical and potentially quite potentially considered to be stigmatizing. How do we go about adjusting language to talk to people in that humanistic way? Is that something you think that GPs have got and they're doing, or is it something that needs an active consideration? How do we turn the clinical into the humanistic, I suppose? It's difficult, isn't it? I mean, it's I guess medical diagnoses can make people feel that they are a patient rather than a person. I don't know. Could I go to you on that, Joss?
Yeah, I mean, I suppose I would say listen to the patient, see where they're at first. Listen first, just listen. What language do they use? Where are they at in their understanding? What their concern, and then work from there. Really, work your way up. And avoid jargon, but there is a way of meeting people where they are, and I think that's really important.
Yeah, thanks. And Hugh, I'll get to you.
Yeah, that doesn't necessarily come naturally to us, and certainly it comes less so to some of us than others. So, I go back to, training. We do need to engage in certain types of training in order to be able to practice in that way. Motivational interviewing is a training that I would suggest that anybody working with in the field should have training in and be proficient in. And and be seen to be applying it and be updated on it. But yeah, I think we need to don't be afraid to put your head up for training for this type of thing. We're not, it doesn't come just because we're doctors, just because there's an MB, MD, whatever after a name, doesn't mean that we know how to do these types of things.
Yeah, thanks you. And I think this might be the final word, Bern. If you
Okay. Yeah, well, I was going to say that I'm kind of the wrong side of 50 to always be correct about how I use language, and I can feel very worried about this. But actually, my experience, my more positive experiences of working in this field is that what makes the most difference is actually the longevity of the relationship. So if I have, and the way that I would say that we need to build that up is we need to be back in the consulting room, generally speaking, in person. I mean, Zoom is very good and it's very flexible, but I don't think it is a substitute for the good old fashioned sitting down in the same room as somebody. And actually seeing the same person over time. Again, it's a plug for general practice, but also in the services that I worked. If I've known someone for 10 years and I've shown up for them and I've had a good day and a bad day and they've had a good day and a bad day, they know that I care about them. They know who I am as a person. We have a connection. And I think that you can get away then with not using the right term, because I'm not, I'm too old to get all this right sometimes. And I can be tripped up. I can be sorry if I've, said something inadvertently, but I don't think the offense I don't feel the offense if we have that relationship. So I think language is a proxy for feeling understood. And the way that we feel understood is that we actually build meaningful relationships, that we can have ruptures and that we can repair, like, mature adults that we hopefully are. So final word.
Yeah, brilliant. Thanks, Bern. So I think what you make about is this all about, and kind of where we started with Joss, actually about competent compassion, is this all about human relationships built fundamentally on safety and trust. And we've heard some really, really good insight about how we improve the chances of that happening. But that seems to be what we've kind of got to, I think, at the end of the day. So all it leads for me is to say thank you to our experts, Hugh, Bern, Joss. It's been really interesting. I think we've looked at the issue from a number of different angles, and I think that's been really, really important. I'd like to just encourage anybody watching to check out the chat function, and if possible, give us feedback on the form. We really do look at all of the feedback. We use that to shape future webinars. We're interested about today, but also about what you'd like to hear from us in future sessions. We will pick up any questions we haven't answered through website, social media. Do join the Anti-Stigma Network. It's free to join. There's a monthly newsletter. You don't need to be a member to take part in any of our webinars, but if you are, it enables us to get you further information more directly. But if you're happier just checking out the website, we also have a number of blog series ongoing with new blogs coming out all the time. We have a new one coming out on Monday or Tuesday in relation to language as well, which picks up on that last point that we made. So thank you very much, everybody. Final thanks just to Rob and Lisa, Fern and Lucy, who helped organise the Anti-Stigma Network across a number of different organisations. And yeah, thank you to everybody. And it's been really nice, really interesting and thought-provoking.